This is a continuation of the other presentation. Other intrapersonal models include elaboration likelihood model of persuasion. And for short, was developed to help explain inconsistencies in the results from research dealing with attitudes. Specifically, this model was designed to explain how persuasion messages or communication can be aimed at changing attitudes and how they were received and processed by people. The information motivation behavioral skills model was initially created to address critical needs for a strong theoretical basis in HIV/AIDS prevention efforts. Since the development, there is evidence to support its usefulness with HIV/AIDS prevention as well as other intervention strategies, including the management of diabetes. According to this model, information, motivation, and behavioral skills are the fundamental determinants of preventative behavior. The information provided needs to be relevant, easily enacted, based on specific circumstances, and serves as a guide to personal preventative behavior. The precaution adoption process model is more recent than the trans-theoretical model, and it's based on decision theory. Its goal is to identify the ideology of personal decision making and the process for putting that knowledge into action. Although the trans-theoretical model and this model are both stage models and appear similar, it is mainly the names that have been given to the stages that are similar. The number of stages is not the same in both of these theories, and those with similar names are defined very differently. This theory includes 7 stages: unengaged, deciding about acting, decide not to act, decide to act, acting, and maintenance, along the full path from ignorance about a specific behavior to taking action and engaging in the behavior. The social cognitive theory is our first interpersonal level theory, and this is between families, friends, peers, fellow students, social groups, socialites. This is between social relationships. It combines the stimulus response theory and cognitive theories. Stimulus response theorists emphasize the role of reinforcement in shaping behavior and belief, and no accounting for the cognitive process. And this is needed to explain behavior, and it can largely be predicted and changed using variables and influences observable in social or built environments. In other words, focusing on the intrapersonal determinants of behavior is not necessarily needed in stimulus response. In this model, reinforcement is considered and a component. We have direct reinforcement, which an example of this is a group facilitator who provides verbal feedback for participants for a job well done. Vicarious reinforcement is having participants observe someone else being reinforced for behaving appropriately. And self-reinforcement is when the participant would keep records of their own behavior, and when behavior was performed appropriately, they would reinforce or reward themselves. This is largely based on behavioral capability, which is when individuals are able to perform specific behaviors, they must know first what the behaviors are and how to perform them. This is largely based on the construct of expectation, which refers to human beings' ability to think and anticipate certain things happening to certain situations. An example is people that enroll in a weight loss program and follow a group facilitator's direction. They actually expect to lose weight. Expectancies are not to be confused with expectations, and these are the values that individuals place on an expected outcome. The construct of self-regulation or self-control is very important in this model and states that individuals may gain control of their behavior through monitoring and adjusting it. This model is also related to efficacy and the efficacy expectations. It's also one of the only theories that talks about collective efficacy. Collective efficacy has been defined as a people's shared belief in their collective ability to act and produce specific changes. Like self-efficacy, collective efficacy is a situation specific. It is a construct that has application when people seek to alter social systems, like neighborhood watches, community organizing, but also has an application in health promotion with regards to health policy. The social capital theory is also interpersonal. It's often defined as the relationships and structures within a community, such as civic participation networks, norms of reciprocity, trust, all these things that promote cooperation and mutual benefit. More recently, it has been defined as the degree of social connectedness. Social capital as a collective asset. It's a feature of communities rather than the property of an individual. As such, individuals both contribute to it and use it, but they cannot own it. There are epidemiological studies that show that greater social capital are linked to several different positive outcomes, such as reduced mortality or access to healthcare. There are also correlational studies that show that the lack of social capital is related to poorer health outcomes. However, as with social networks, a cause-effect relationship has not been established between social capital and better health. Social capital is an important descriptor of community wellness, but it is not a strategy that requires community organizing and capacity building. When we talk about the social capital theory, we need to talk about network resources. When we talk about network resources, we talk about bonding social capital. This is also referred to as exclusive social capital. It's defined as the type that brings closer together people who already know each other. We talk about bridging social capital. It's referred to as inclusive social capital, and it's defined as the type that brings together people or groups who previously did not know each other. When we talk about linking social capital, it's this type of network, and social capital comes from relationships between or among individuals with institutions and individuals with relative power over them. An example would be a boss and an employee that work on a project together. The social network theory is also interpersonal, and it actually is defined as a web of social relationships that surround people and the structural characteristics of that web. It is created to describe social relationships and characteristics that can't actually be described through traditional social units like family. This is more inclusive and talking about communities. To support health education specialists' work, there is now evidence from social epidemiological observation studies that have documented the beneficial effects of supportive networks on the health status. When we talk about social network theory, we talk about the benefits of these supportive networks and the web of social networks that exists. There are some important things to consider when we talk about this, and it's centrality versus marginality of individuals in the network. When we talk about it, it's how much involvement does the person have in the network? The reciprocity of relationships. Are relationships one way or two way? Complexity or intensity of relationships in the network. Are the relationships between two people or are they multiplexed? Homogeneity or diversity of people in the network, the subgroups or clique that might exist within the network, and the communication patterns that are within the network. In summary, we know that social networks can impact health, but the specifics of who is most impacted and how best to set it up and use the social networks are still unknown. Nevertheless, because the impact of social networks, health education specialists and public health practitioners agree that planning interventions at this level need to be considered to move health outcomes forward. Diffusion theory is another interpersonal model, and it's actually defined or explained as the spread of innovations. This is something new, like a product or a service or a program, and it's usually within a population. Stated in another way, it explains the pattern of adopting innovations. Like other processes that we've discussed, adoption is situation specific, and it results from people going through a series of stages. The adoption pattern can be represented by a normal bell curve. The individuals who fall in the portion of the curve to the left are actually the innovators, the ones that adopt early. The normal bell curve goes through early adopters, early majority, late majority, until it hits the laggards. And the laggards are those that don't join in until everybody else has joined in. There are 5 stages associated with this, which include knowledge, persuasion, decision, implementation, and confirmation. Community readiness model is another interpersonal theory or model, and it's the degree to which a community is willing and prepared to take an action. Like with individuals, communities are in different levels of readiness for change. The community readiness model is a stage theory for communities, and it was actually developed in the 1990s. When we talk about this model, it's actually a stage theory for communities. Some of this model has 9 stages, starting with no awareness. The problem is not generally recognized by the people, to denial. There is little or no recognition in the community that there is a problem. Vague awareness, feeling among some in the community that there is a problem and something should be done. Pre-planning, a clear recognition by some that there is a problem and something should be done. Preparation, there is planning going on, but it is not based on collected data. Initiation, information is available to justify and begin efforts. Stabilization, program is running, staffed, and supported by the community and decision makers. Confirmation and expansion, standard efforts are in place and supported by the community and decision makers. Professionalism. Much is known about the prevalence, risk factors, and cause of the problems. Highly trained staff run effective programs and aimed at the general population and appropriate subgroups. After we've learned about several different models and theories, it's not inclusive of all models and theories that can be used in public health, but it is a lot to give examples by. It's important to talk about how you might apply this or how you can go through a decision-making process in terms of selecting the correct model for your health program. It is very important to recognize that behavior change most likely occurs because of one of these theories has taken place within your population or within an individual. Therefore, it's really, really, really important to do some research and to look at populations that are similar to yours. So if you're looking at an urban population, look at another urban population. If you're looking at a population within healthcare, look at another healthcare population. Look at what has worked within the population. Also look at what has worked with similar interventions. It may not be the same intervention, but look at education in diabetes, look at education in cardiovascular disease. It's very important to do research to see what has worked previously, because it's likely that that theory or model can be applied to your health program planning. The next step is to develop a problem statement. In this step, you identify the problem that needs to be changed, and it tends to be relatively simple or straightforward, especially if you're working in a setting where the problem has actually already been defined, like you should have already done. Then you have to identify a target behavior. It is potentially the most important step in the process. Identifying the appropriate target behavior will actually help you focus your efforts. Then you define the priority population, which you probably or likely have already done. You might also find it helpful to be very specific concerning the priority population. An example is in addressing obesity, we might say too many American adults consume too large of food portions. In this way, we have identified the target behavior and the direction for the change. Then we want to conduct a functional assessment. Functions of behavior refer to the reasons or causes for behavior. Functional assessments can be conducted in many ways, but usually refer to a process where we collect information about a behavior. It can be done using surveys or direct observations about the behavior. It can also be done through the review of literature, or basically researching the surrounding behavior. This step aims to identify the major reasons why target behavior is not happening, or the major reasons why a problem behavior is happening. After this, we can finally select a theory or model. With a comprehensive understanding of the functions of the target behavior, we can select a model or theory that includes constructs that align most closely with the behavior's functions. After this, then we can develop our intervention. I do want to go over some limitations of theories. They are not universally functional, which means that you cannot universally apply one theory to all health interventions. There are specific theories that can help guide and help provide framework for a specific health intervention or a specific population. If we use the correct one, we can actually increase the success of a health program. If we use the wrong one, we can actually decrease the success of a health program. So it's very important to consider these theories and these constructs when we're moving forward. Again, I'm going to highlight and stress that we need to use evidence-based practice as a guide. So we need to research both our health problem and our population. And we need to utilize models that have worked in either of these. This is the reference for this presentation and the preceding presentation.